Bismillahir Rahmanir Rahim. Our case today very interesting. Preterm 33 weeks admitted to NICU due to severe RDS to rule out early onset neonatal sepsis. Low birth weight 1.7 kg. Maternal history: mother gravida 3, bara 2, no maternal risk factor disease or received any medications. Outcome: baby boy, preterm, 33 weeks, low birth weight, 1.7 kg, required initial steps of resuscitations. After 30-second, baby apneic, heart rate 90 beat per minute, cyanosis, for which required positive pressure ventilation. So the indication for positive pressure ventilation: apnea, gasping, heart rate less than 100, cyanosis. After 30 seconds from positive pressure ventilation, still the baby is not showing any spontaneous breathing or effective breathing, apneic with respiratory distress, for which baby intubated and received 1 dose or first dose of surfactant. After stabilization, baby transferred to NICU, connected to mechanical ventilation, BC, AC, BIB 20/6, and FI2 oxygen 60% rate, 50 cycle per minute, septic workup taking and started antibiotic, ampicillin, gentamicin. Chest X-ray requested, showed what? Evidence of RDS. Evidence of RDS. What is the evidence of RDS in X-ray? Ground glass appearance, air bronchogram, and small lung volume or atelectasis. So this is the 3 finding in the X-ray for the RDS. It will be ground glass appearance, air bronchogram, small lung volume or atelectasis. EPG done is acceptable. So what is the message from this case, or the key points? The summary is the tune from the case. First, what are the indications for positive pressure ventilation? Baby apneic, gasping, or heart rate less than 100 beat per minute, cyanosis, or the baby is not improved on oxygen. So there is 3 indication for positive pressure ventilation: apneic, gasping, and heart rate less than 100 beat per minute, cyanosis, or the baby is not improved in the free flow oxygen. The second key point, indication for surfactant replacement therapy. In such case, neonate with clinically and radiologically or laboratory evidence of RDS. Clinically, there is respiratory distress or respiratory failure. Respiratory distress, this means the baby tachypneic with retraction, subcostal, intercostal retraction or grunting, or respiratory failure, apnea or cyanosis. And radiological evidence of RDS. What is the radiological evidence of RDS? It will be air bronchogram, ground glass appearance, small lung volume or atelectasis. Or laboratory evidence, it will be EPG having respiratory failure, FI2 oxygen less than 60, and also the PCO2 more than 60. The second indication for surfactant replacement therapy, it will be infant who require endotracheal intubation and mechanical ventilation secondary to what? Respiratory failure. So any baby in the delivery room required intubation, this is one of the indication for surfactant replacement therapy. The third key point, you have to take septic workup in the baby with respiratory distress, because it's difficult to distinguish or to differentiate respiratory distress from congenital pneumonia. So the key point, the indication for positive pressure ventilation: baby apneic, gasping, heart rate less than 100 beat per minute, cyanosis. Indication for surfactant replacement therapy in such a case: neonate with clinically and radiologically or laboratory evidence of RDS. Clinically, respiratory distress and respiratory failure, respiratory distress, tachypnea and retraction, grunting, respiratory failure, apnea and cyanosis. Radiological finding of RDS, it will be ground glass appearance, air bronchogram, small lung volume or atelectasis. Laboratory EPG, it will be respiratory failure, PCO2 is more than 60, and FI2 oxygen will be less than 60. And the third key point, septic workup, you have to take it with patient with respiratory distress, because it's difficult to distinguish or to differentiate RDS from congenital pneumonia. ومن أحياها فكأنما أحيا الناس جميعا. شكرا، سلام عليكم.